Which of the following changes are expected to occur if this patient is enrolled in this trial? A 55-year-old man presents to the ED with shortness of breath and weakness. Past medical history includes coronary artery disease, arterial hypertension, and chronic heart failure. He reports that the symptoms started around 2 weeks ago and they worsened gradually. His vital signs are temperature is fine, blood pressure is 135 over 90, heart rate is 95, respiratory rate is 24, and oxygen saturation is 94. So this is slightly on the lower side. Your normal oxygen saturation is above 96. And when do you hospitalize a patient? With COVID, I think you all should know this. You're all medical students. When would you, after what saturation is home isolation, not preferred anymore, and you need to hospitalize the patient? It is 92. Okay. So below 92, you should hospitalize the patient, and below 88, you should ideally admit the patient in the ICU. Okay. So that's why we tell all the patients on home isolation that do keep a pulse ox with you. Okay, so where were we? Okay, so the examination reveals mild jugular venous distension. Auscultation reveals bilateral loud crackles. Pitting and edema of the lower extremities is noted symmetrically. The patient's plasma BNP level is 500, right? So normally your BNP is less than 125. Here the BNP is elevated based on a rapid bedside assay. Now BNP is very sensitive for what disease? CHF, congestive heart failure, all right? So BNP is a very sensitive marker for congestive heart failure, and it is increased. The chest X-ray shows an enlarged cardiac silhouette. He is diagnosed with acute chronic left heart failure and pulmonary edema, warranting immediate treatment with furosemide. The physician proposes a drug trial with a new BNP stabilizing agent. So what is the drug that stabilizes BNP? Nesiritide is your neprilysin inhibitor. No, sorry, nesiritide is actually the other word for it's actually sacubitril. Okay. So what sacubitril does is it inhibits the neprilysin and hence prevents the breakdown of BNP. Nesiritide is just the analog. But both of them function the same. They just help in increasing the BNP. It's just that one stops the metabolism and the other one is just the analog. So which of the following changes are expected to occur if the patient is enrolled in the trial? So the option would be natriuresis, correct? And it would decrease aldosterone release. Okay, so there are two types. First question, where is the natural BNP released from? What part of the heart or what part of the body? Ventricle, correct. And ultimately what BNP does is your heart, so you have two types of natriuretic peptides. You have ANP, which is released from your atrium, and then you have BNP, which is released from the left ventricle. So in case of volume overload, which you usually see in cases of CHF, your myocytes on the heart stretch, right? So that stretch activates the BNP release and ANP release from the atrium. And ultimately what they do is they cause natriuresis. So they get rid of excessive sodium and they get rid of excess of water in the body. Now, because they're getting rid of that, right? Ultimately, the problem in heart failure is that you have excess of third water, excess of fluid in the third spaces. So we are getting rid of that. Also, what they do is they dilate the afferent arterioles and hence they increase the GFR so that the body can get rid of the excess of fluid. Ultimately, what it does is it also decreases the release of aldosterone, because what is the function of aldosterone? It causes retention of sodium and water, and we don't want that, especially if you are facing heart failure. So it is going to decrease aldosterone. So BNP, you have ANP and BNP, and what they do is they increase the GFR, they cause natriuresis, they cause relaxation in your atrioles and venules, and they're going to decrease the aldosterone secretion. Okay, so first is your atrial tachycardia. So this is PSVT. In PSVT, you're going to get a a heart rate of around more than 150. Okay, so that's another, like, it's not permanent, but this is like a clue for you. If your heart rate is more than 150, it's going to be PSVT, and if it is usually less than 150, it's going to be AFib. Okay, but always look for, the P wave morphology. The P wave is often not visible because it's usually buried in the QRS complex. You're going to get narrow QRS complex, and the most important differentiating factor is that your RR intervals are going to be equal. Okay, in your AFib, it's going to be irregular. So the murmur actually starts from here. Okay, this is the normal, and from here is the beginning of your supraventricular tachycardia. You can see, the P waves would usually be buried because it's of such a high heart rate, but you're going to get usually equal RR intervals. Okay, let's go ahead to the next EKG. So here, so this is normal sinus tachycardia. You see, all the waves are normal, the RR interval is normal, your QRS is narrow, and you can actually appreciate the P waves, right? So P, QRS, and T. Can everybody see? P, QRS, and T. So the P wave is actually visible. The P wave is visible, and you see normal RR intervals. This is going to be sinus tachycardia. So P waves would usually be before the QRS complex. The ventricular rate is of course more than 100 because it's tachycardia, and your maximum heart rate can be determined. It's 220 minus the age of the patient. So that's how you're going to get it. PR interval is going to be more than 120 seconds. Okay, what do you see here? Now this is actually a no judgment zone, right? So don't mind if I'm taking your names, but look, just pay attention to the RR intervals. Can you see here this gap and this gap and this gap and this gap? Is it equal or unequal? It's unequal. So it's going to be, see, the narrow, you can clearly see it's narrow QRS complex, right? You can clearly see that there is no P wave. Anywhere in the long lead, I'm not seeing any single P wave, right? And also the RR interval is unequal. So this is going to be, yes, it's going to be AFib. Okay, let's see this. So someone told that this is going to be atrial flutter. Now, do you see the difference between these waves and the previous? These are the flutter waves, okay? All these waves that you get, these are the flutter waves, and this is atrial flutter. It usually would be like in the ratio of 2:1 or 3:1, but these are the flutter waves, and you should identify them, okay? Okay, now let's see the worst Parkinson's, okay? So let's see. Okay, and hence your PR, see, this is like a zoomed in image of the delta wave. So your PR interval is shortened, so it's less than 120 milliseconds, you can count. So it's going to be less than 3 small boxes. Okay, 1 small box is 40 milliseconds, right? PR interval is smaller, QRS is clearly widened, right? And the T wave inversion might be there, might not be there. So it is something very non-specific, you don't need to look for it, okay? Yes, the main difference between PSVT and AFib is the RR interval, and also in PSVT you might have the P wave, but because of the tachycardia, the P wave is usually embedded in the QRS complex and you're not going to appreciate it. Whereas in AFib you don't get the P wave. But that's why I'm saying that don't look at the P wave, look at the RR intervals to do the differentiation. Can you see the difference in the height in all of these QRS complexes? Here. Okay, and what does that suggest of? In LVH, LVH is maybe one of the other slides. So it's actually electrical alterance. Okay, so in electrical alterance, you get different sizes of the QRS waves, and it is suggestive of a large pericardial effusion, right? So something in cardiac tamponade. Always remember electrical alterance, different sizes of the QRS. See here. So different waves of QRS, different sizes of the QRS complexes. You see, and with a narrow QRS complex, so it's narrow here, and you see it in large pericardial effusion or cardiac tamponade. Now, look at this ECG and tell me what is going on. So this is left ventricular hypertrophy, okay? So in left ventricular hypertrophy, you're going to get really long Q waves, okay? So all of these are like, look at how big they are. So this is suggestive of hypertrophy. Okay. Now next, this is how your VFib is going to be. So in VFib, this is like the worst type of arrhythmia out there, right? You're not going to get any P wave, no QRS, no T. It's all going to be haywire. It's obviously widened QRS. So I told you in your ventricular tachycardias, you're going to get a widened QRS, and basically you're going to get an chaotic irregular waveforms. So this is going to be your VFib. Okay.
Thanks for watching. Please give a thumbs up and subscribe for more.